Dr. Sanchez, thank you. All right, so this is a very controversial topic of placing stent grafts outside of their instructions for use. This is a project that we worked on a couple years ago, and the manuscript is actually published in the Journal of Vascular Surgery for those that are interested in reading more about it. Some background, as we all know, that AAA is the 15th leading cause of mortality in the United States, and the 10th leading cause of mortality in men over the age of 55. The treatment of AAA has come a long way from aortic ligation and open repair to endovascular aneurysm repair. And after first FDA approval in 1999, EVAR has really dominated the treatment of abdominal aortic aneurysms. In 2003, that really was an inflection point, or marked a time where the number of EVARs performed exceeded that of the number of open aneurysm repairs. Now, each device has its own instructions for use. This is very, very device specific. These things include everything from aortic neck diameter, aortic neck length, angulation, iliac fixation length, iliac diameters, tortuosity, and other aneurysm features that the manufacturer deems as important. Now, adherence to IFU remains low across the board. A number of people have studied this. Dr. Schanzer had looked at this and looked at both conservative and liberal adherence and found that it ranged somewhere between 42 and 69%. Other studies have showed 58% and 61% adherence to IFU. So the effects of IFU adherence and non-adherence on outcomes is still up in the air. So in our population, we looked at patients over an 11-year time period, and we mainly included patients that had preoperative, postoperative imaging, all the perioperative details, patient information, including follow-up information, and had adequate postoperative imaging to perform 3D reconstructions on all these patients and perform centerline measurements to acquire the data. So after doing this and acquiring all this data, we began our analysis. And our main endpoints were all-cause mortality, aneurysm-related mortality, and we looked at a number of secondary endpoints such as endoleak rates, reintervention rates, late-onset rupture, aneurysm sac enlargement, and then any perioperative or operative complications. So we started off with 900 patients. We reduced that down to 566 patients after excluding patients that presented with an aneurysm rupture, patients that had stent grafts placed for indications other than an infrarenal aneurysm, patients who had their index procedure performed at an outside institution but were referred to us subsequently for reintervention. Those patients were excluded. And for those patients where there were gaps in imaging or follow-up, of course, those patients were also excluded. Now, to highlight, when we looked at our cohort, a number of different devices were used over time. Certain devices we were more in IFU than not. For example, with Medtronic, where Anurex and Endurant, where the proximal neck criteria was, say, 10 millimeters, we were more likely to be in IFU for all criteria. But overall, we were within all IFU criteria around 31% of the time. That means we were outside around 68% of the time. In general, the characteristics between the two cohorts, those that were within IFU and those that were outside of IFU, were very similar. The comorbidities were also very similar between the two groups. Now, regarding the specific anatomic criteria that we violated, we were most often within IFU for the proximal aortic diameter and length, and for the neck angulation, the proximal neck angulation. We were also very compliant with the length of the iliac that we were sealing in. We seemed to violate the iliac artery diameter, either too big or too small, most often, about 50% of the time. Now, when we look at primary outcomes, and I think this is the most important finding, is that the all-cause mortality and the AAA-related mortality was similar between the two groups out to a follow-up of around 3.5 years. All right, now when we look at secondary outcomes, mainly intraoperative complications and endo leak rates, the most substantial finding is that the need for transfusion seemed higher in those patients that were treated outside of IFU. Can't say for sure, but this is likely due to more complex procedures requiring longer procedure time, et cetera. Otherwise, perioperative complication rate, endo leak rates were very similar between the two groups. The length of stay was similar between the two groups. Additional secondary outcomes, also similar between the two groups. Again, reintervention, all endo leaks and specific endo leaks, all very similar between those two groups. Now, there was no difference in the primary outcome seen when violating the aortic neck length and angulation. That's important. Interestingly, we found that violating the proximal aortic neck diameter seemed protective. I think this is a statistical error, more likely than anything else. The alternative explanation for this is that maybe we just haven't found the sweet spot for degree of oversizing with regard to the proximal neck. And again, when looking at secondary outcomes, overall very, very similar between the two groups. Again, we found this finding where the proximal neck diameter, violating this proximal neck diameter, seemed to have some type of protective effect against endo leak rates. Again, can't fully explain that based on this data. So just to kind of discuss this topic in a little bit more detail, in our study, we were adherent to all IFU criteria around 31% of the time. That is much lower than previously quoted in Dr. Schanzer's study, as well as other studies, which was around somewhere between 42%, 69%, depending on the study that was looked at. Possible reasons for this include the fact that we're a tertiary center. We see a lot of complex disease. That is one possible explanation. We've also had multiple IDEs to be able to treat these more complicated aneurysms. That's another possible explanation. And we had to exclude certain patients where they didn't have adequate imaging follow-up or subsequent CT scans, and maybe those patients had so-called chip shot aneurysms where they were followed with duplex or other modalities because of the low-risk nature of those type of aneurysms. We found that non-adherence was mostly due to the iliac artery diameter, and we were within IFU for the proximal aortic neck diameter most of the time. And there was no difference between men and women with regard to this. Other studies also found no difference in all-cause mortality and AAA mortality. Walker and Lee et al. All found this. Dr. Schanzer mainly found that if you violated IFU, you were more likely to have aneurysm sac enlargement, which acted as a surrogate for future aortic-related complications. I'll end with that since we're over time. Thank you so much.